Okay, last but not least, we have Dr. Professor Wei Chun Chuang from Taiwan, who is going to share with us a nightmare in Lerich syndrome.
Thank you, Dr. Kong. Dr. Hui, thank you. Thanks for your invitation. Now I present case to manage the Lerich syndrome case. This is my CV. The patient is a 69 years male. He has a stage 3 CKD and also smoking, diabetes, hypertension, stroke, and also CAD. He suffered from critical limb ischemia. So from the coronary artery angiogram, we can see the triple vessel disease for the patient. And we did the ABI index for the patient. The right side index about 0.49 and the left side is 0.60. So we perform the CTA for the patient. So from the CTA, you can see from the aorta after just below the left side renal artery. So we can see the total occlusion of abdominal aorta and also bilateral iliac artery. So we decided to call our friend, cardiac surgeon, for survey the operation for the patient. But it's a high risk of operation, so the surgery was turned down. But because the symptoms, so we decided to do the angiogram for the patient. So from the angiogram, we did the angiogram from right side brachial artery. So we can see there's a total occlusion just below the left side renal artery. Because the patient have the poor renal function, we try to protect the kidney as well. So we decided to first to puncture the left side femoral approach. So we use sonoguide puncture and the 0.025 wire and use a balloon to support the wire. But actually it's a total occlusion, so it's difficult to advance. So we cannot close the coronary total occlusion lesion. So we decided to do the right side femoral approach puncture. Also use the sonoguide. You can see the choroidal up to the abdominal aorta, but we still cannot close the CTO from the right side femoral approach. So we did another puncture for right side brachial approach. So we use the JR46 the guiding and use a round through try to close the lesion. So from the lesion, you can see the very stiff, very hard. So it's difficult to advance the round through wire. So we use another ultimate bolstering wire. Use parallel wire for the technique to try to close to the any side of the femoral artery. So we can see the wire almost going to the right side femoral artery, but it's in the fourth lumen. So we did the cut for the patient. And actually the right side brachial artery is difficult to close the CTO. So we did the control antegrade and retrograde tracking. So we did the balloon dilatation 3.0 emerge balloon dilatation for 5 times, about 6 ATM for the patient. So, but it's still difficult. We advance the wire from right side femoral approach, but still cannot go into the true lumen. So when you do the reverse cut, we use a 5.040 extreme balloon dilatation from the right side femoral artery area, about 4 ATM for 6 times. So finally, we are lucky we can close the 0.025 wire to close the coronary total occlusion into the abdominal aorta. So now we try to, after creation the route from aorta to right side femoral route, so we try to create another route to the left side femoral artery. And we use the kissing balloon, and the left side with the 5.040 and the right side use the 0.080. And we try to produce another fourth lumen, the cut to advance wire from the left side femoral artery. So actually, you can see it's still difficult to enter the true lumen from after the cut balloon dilatation. So finally, we after about half hours, we close the wire to the true lumen, so for the abdominal aorta artery. So now I think this is not so difficult to just put the stent, but you know, we did the kissing balloon to open up all the root, aorta root to the right side femoral artery and the left side femoral artery, use 7.0 and 6.0. So now we have to decide to put the two stent, wire bond stent. One we use 8 mm, 75 centimeter, another one use a wire bond 120 centimeter. But how to put the position of stent is another consideration. So if we put the, because you can see right side renal artery is higher than the left side renal artery. If we put the just right, like right side, we put the stent with the same height, maybe we'll induce the plaque to block the migration to the left side renal artery to occlude the left side renal artery. But so we decided to use a different right side stent will be higher than the left side stent to prevent this plaque migration. But actually, we also afraid in the future maybe the right side wire bond will have a poor support to fall down to accrue the left side wire bonds. There's another issue. So maybe we have to shorten the height between two different stents. So finally, we implant stent and do the post dilatation for this patient. And after the image, we can see still a plaque in the junctional area. So we put another wire bond 8 mm 75 centimeter stent from the left side femoral artery, the orifice. And after angiography, we can see there's still some stenosis. We can see there's still, after stenting, we can see some of stenosis in the left side distal renal artery. So, okay, so we can see the right side. So we use a PTA for distal femoral artery. We didn't put another stent for the distal left side femoral artery. And for the, how about the right side? We can see the right side, there's a severe dissection in the femoral artery. So we put another, we didn't use wire bond, use the Everflex cell expandable stent for the patient. So welcome to Taipei in next year. We have March 7 and 8. We have a meeting, global AMI meeting in Taiwan. Welcome, join our meeting. Actually, the Lerich syndrome is first described by Renaud Lerich. Is a French vascular surgeon. Is also physiologist. And the clinical trial, including the claudication, impotency, and the decreased pulsation. And that means the aortoiliac occlusion. So usually it will be a male and also strong association with smoking. So the lifestyle drug is very important. So surgical, including the aortobilateral pass, actually is difficult operation for surgery. That's why our surgeons don't want to do this procedure. And another choice is axial bifemoral bypass, may be more easily than aorta bifemoral artery. You don't have to go into the abdomen. Another one is the endovascular procedure. So after the stenting, we find there's another problem. We see the even after stenting, we see the leak of the vessel in the right side femoral artery. So we have to put we has a major the ACT and use potassium and put another wire bond 75 centimeter for this lesion. So after 5 standing, so we can see we already see the leak. So the patient, we follow up the patient by the CTA. So from the CTA, we can see the stenting and also pattern of the vessel for the patient from a 3D view or different kind of view. So in summary, the endovascular procedure is feasible to manage the Lerich syndrome, and the cut, also reverse cut, can be used in PTA for Lerich syndrome. And the CTA is a good tool to prevent intervention and also follow up. And we also announced the APAC will be in Taipei in 2027. So in the February 20, please keep the date for February 20 and the 21st. It will be in Lantern Festival in Taipei. Thanks for your attention. Thanks again for Dr. Q's invitation this last year and this year. Thank you so much.
Yeah, thank you very much. But one question: why don't you use the big stand for aorta from the for abdominal aorta? Then you use two stand, two small stand for femoral.
Yes, there's another choice. Use to aorta stent for this patient. But because the surgeon, because I don't know how to do the big stent for the patient, and also in the previous experience, usually we use a two stent can maintain the vessel to two vessel very good. So, but maybe in the future we can cooperation with the cardiac surgeon to put the aorta stent for this patient, and also the wire bond for the distal femoral artery.
Yeah, because if you put the cover stand for aorta and you put two small stand is better. Yeah, if you want to do the renal artery later, yeah, because a patient maybe develop the renal artery stenosis is more yeah, to engage to the renal artery, yeah, osseum. Yeah, what do you think, Dr. Quang Tuấn?
So I agree with Dr. Wei, because the pathology in this patient is very different in the stenosis in the aorta. So I agree with you to a small stand for the both femoral.
Okay, and
Actually,
Dr.
sorry. Actually, I love doing these cases because you go from brachial and then you just push down with a Terumo wire 035 with a straight, and then change over to a curve, and then you snare from below. When you go from below, you tend to go into subintimal, and it's very difficult to go up. So it's much easier from above, and then large stand, and then a kissing stand. But the only thing I've also learned is that we had problem. I don't really like to do where the occlusion is right at the margin of the renal, because sometimes when you go out and then you have got to stand, you actually lose the renal artery and also the superior mesenteric artery. I had one case, and that was way back about two decades ago, and patient actually died. So I've always been wary, and I tend to do if it's slightly lower than the renal artery. So if you have any problems of dissection, then at least it will not affect the renal arteries and also mesenteric artery. But nicely done.
Thank you, because it's a wire bond stent, is a graft stent, so we have to away from the renal artery to prevent the occlusion of renal artery. Actually, we use a CTA to follow the patient. I think the two stents still pattern, and the patient is very old, and they also have a stroke CKD. I think maybe it's a kind of choice for the patient to improve his symptom.
Okay, I think, yeah, that was a great discussion. I think we should wrap up.